Most chronic diseases do not start with a prescription. They start years earlier with lifestyle. Hi, I'm George, a UK hospital pharmacist, with a significant part of my clinical role being in a hypertension clinic, where we review blood pressures, underlying causes of hypertension, known as secondary causes, cardiovascular risk, and long-term outcomes in those hypertensive patients. What I see repeatedly is blood pressure being caught late with underlying lifestyle issues driving that hypertensive diagnosis. The blood pressure being raised quietly over many years, driven by lifestyle factors such as weight, diet, salt intake, poor sleep, and inactivity, resulting in end organ damage, which at the very first point could have been prevented fairly easily. And so by the time they reach this stage, sometimes there are multiple agents and it is incredibly hard, if not impossible, to reverse the damage that has been done. So why am I making this video? Why are pharmacists and healthcare professionals so integral to this? But over the last decade or more, the evidence has become incredibly clear. Lifestyle interventions are no longer seen as merely supplementary, but they are fundamental to outcomes in these chronic health issues, such as hypertension, which we're using to focus in on these lifestyle interventions in relation to the disease outcomes itself. So the aim of this video is simple and practical. By the end, I want you to be able to highlight measurable impact from lifestyle intervention choices, show that interventions are evidence-based and science-backed, being clinically powerful tools in our arsenal to combat hypertension and other chronic diseases. They are not just soft advice. I also want to be able to empower pharmacists and other healthcare professionals listening to this to confidently explore lifestyle interventions and lifestyle factors contributing to their patient's current presentation and incorporating these techniques and ideas into your everyday practice. And finally, I hope you can reframe your understanding of lifestyle interventions with them being core clinical work, not just an optional extra. Now, this video isn't about replacing or talking against medicines. They are fundamental to positive patient outcomes, but it's about using lifestyle interventions ahead of and definitely supplementary to medications to get the best patient outcome possible, because using medicines on their own does not at times address the root cause. So why did I decide to create the video, and why is there such a big movement towards lifestyle interventions? So first off, lifestyle interventions are something that we can all do. Everyone has the power to impact their own and other people's lifestyles to improve long-term clinical outcomes. And we all know there is a big science base behind these lifestyle interventions. If you look at hypertension, for example, over the last decade or so, there has been a clear shift in putting lifestyle interventions ahead of and definitely additional to medication agent use. Lifestyle interventions are now consistently emphasized as first line, essential alongside medications, and fundamental to long-term outcomes and clinical prevention and risk reduction. And this is because hypertension, along with most other chronic diseases, are not acute failures. They are slow cumulative results of our behavior, our lifestyle, our diet, and our environment. And data has shown repeatedly that medications alone cannot compensate for failures in any of these areas. Now, before we delve further into the lifestyle factors, I do want to be clear that there are things called secondary causes which are driving that primary diagnosis. For example, with hypertension, we need to screen out for any secondary causes of hypertension prior to making any primary prevention or lifestyle prevention interventions. So pharmacists and clinicians in the hypertensive sense should be alert to renal disease, endocrine cases such as thyroid issues, aldosteronism. We also need to be aware of medications and other herbal OTC medications that can drive hypertension up and therefore become substance-induced hypertension. And we also need to be aware of a person's diet, and I'll come on to that in a second with licorice. In these cases where the primary diagnosis of hypertension is being driven by a secondary cause, no amount of lifestyle interventions is going to correct those secondary causes. Therefore, good prevention always starts with good assessment. Now, the licorice effect, and this one is kind of a golden egg in your in your arsenal. You may not see many people with this, but it's something that will always stick in my mind. Excessive licorice intake can drive severe hypertension. Now, this is all down to licorice containing a component that basically mimics mineralocorticoid activity, therefore leading to sodium retention, potassium loss, and severe hypertension. Obviously, sources can include licorice itself, but also many over-the-counter and herbal remedies may include this ingredient, so it's always good, as we just mentioned, around doing a good assessment to screen out any of those things that could be driving hypertension. And that is why you pharmacists are uniquely positioned, because we have those medicine use review and over-the-counter conversations with those patients. Now, as I mentioned, antihypertensives do save lives and they do work really well, but they primarily treat that blood pressure number, not the underlying system or root cause. Without addressing lifestyle drivers, medication doses will escalate, polypharmacy will increase, which has its own issues down the line, especially as that polypharmacy increases, but also patients feel disheartened when they put on a medication and then it continues to increase and they multiply. And the long-term risk, because that driver is still there, remains excessively high, and therefore that long-term risk does not necessarily reduce. In clinics, prescriptions change, but the trajectory of the disease sometimes does not. So, lifestyle interventions, what actual impact can they make? And now this is where knowledge and empowerment comes from. Just looking at a few points here in relation to hypertension, we can see they basically mirror first-line antihypertensive agents. Weight loss, for example. So every kilogram that we can lose, we lose 1 millimole of mercury in the systolic reading. Therefore, 5 to 10 kilo weight loss can match first-line antihypertensives. Also, by changing our diet, and the DASH diet is one that is definitely recommended in relation to hypertensive cases, we can see up to an 11 millimoles of mercury in that systolic blood pressure reading, with a 5 to 6 millimoles of mercury reduction in that diastolic pressure. Again, these are clinically significant changes. Sodium reduction, so lowering it down to those guideline levels of around 6 grams per day, we can see a 5 to 6 millimoles of mercury reduction in our systolic pressure, and this is also exponentiated in those with renal disease and those of older age with established hypertension. Regular physical activity, we can see a 4 to 9 millimoles of mercury reduction in that systolic pressure. And also, this doesn't just have to be cardio training like running, cycling, etc. Resistance training adds additional benefits in terms of muscle growth that are fundamental to a healthy body and lifestyle. And alcohol reduction, yes, in short, no alcohol in our diet is best, but in just reducing it down, we can also see a 4 to 6 millimoles of mercury reduction in that systolic pressure. And a key thing with all of these, anyone can do them. They are free. And I say that obviously a diet can cost, gym membership can cost, new running trainers can cost, but they're clinically meaningful. They are dose dependent to a level, i.e. the better we get, the more trained we get, the better our diet gets, the more dialed in, the more weight loss we have, the increased benefits we will see. But also they compound each other. You can do one, and then once that's been locked in, do another one. And therefore we can clinically mimic what an antihypertensive agent can do, which can sometimes have side effects, with a lifestyle intervention in a synonymous way. So in short, lifestyle interventions aren't just generic advice, they are fundamental tools in our arsenal to combating hypertension and chronic diseases. So how can you incorporate this into your practice? These interventions, these conversations do not require long consultations. It just requires intentionality. In my hypertension clinics, I always discuss blood pressure alongside sleep, alongside diet, alongside lifestyle, alongside activity, alongside stress, and I always focus on one change at a time. Let's not overwhelm our patients. They are deep-seated in their own lifestyles. We do not want to shock them too much, as they will resist change. But reinforcing consistently, calmly, and authoritatively over multiple contacts, ensuring our conversations are framed with support and encouragement, these corrective measures can be sustainable. Having this approach I've found to be realistic, repeatable, and scalable. And when lifestyle improves, medication becomes efficacious, and therefore we can reduce the amount of agents and the doses that those patients are on. Therefore, less is required in the future, and those patients are empowered to to control their own outcome. So why am I making this video? Why are pharmacists and healthcare professionals so integral to this? So just taking pharmacy and pharmacists as an example, we are on the front line. We see patients in the community and in secondary care daily. We have built longitudinal relationships with these patients, especially in community. You might know them by first name, you might know their family, their friends, you might know their whole network. And we can intervene early, long before they're in the consultant's room being told about their diagnosis. And we as pharmacists are already doing this, especially on the high street in community pharmacies. We're doing blood pressure checks, we're doing wellness checks, we're reviewing medications, we're doing smoke and cessation services, we're having routine consultations, especially now with Pharmacy First being ever present and fundamental to the last few years' success of pharmacy in the NHS. We are integral to these prevention opportunities. Now, I'm not saying we're replacing the specialists, but we are helping to bridge the gap between evidence and everyday behaviour. Some of the most impactful work I do in my hypertension clinics is changing someone's understanding that lifestyle is sometimes on par or more beneficial to the outcomes of their condition, rather than just simply adding in and titrating up medication dosages. I can change the direction of someone's outcomes by simple lifestyle interventions and educating them as why we're telling them. So the take-home message from this video: the last decade or more has taught us something fundamentally important in healthcare. Chronic diseases cannot be solved by downstream intervention. We have to look upstream, and the hypertension clinics that I'm involved with show this as a blueprint. We screen appropriately, we assess lifestyle interventions early, we use medication wisely, and we improve long-term outcomes with less agents. Some of the most important clinical work is never about changing the prescription. It's about changing the direction of someone's life. So that's all for me today. If you're a pharmacist or healthcare professional, I'd like to know if lifestyle intervention conversations are currently embedded in your practice. And if not, I hope this video helps you to be empowered with the data to show why these lifestyle interventions are so fundamental to patient outcomes. If you found this video helpful, like, subscribe for more evidence-based conversations directly from a UK pharmacist, and comment below if you feel like I've missed anything in this video, because pharmacy and healthcare is so much more than just giving people medications. It is about changing the direction of our life. Have a great day. All the best, George.